I was invited here at HOPA to speak on updates in urothelial carcinoma. My presentation really covered the disease state from the beginning when patients are early diagnosed with non-muscle invasive disease and went through the different stages that patients can present. So we began with talking about non-muscle invasive disease and how the standard of care is still undergoing a transurethral resection of the urinary bladder tumor. We talked about intravesicular chemotherapy versus immunotherapy. Usually in non-muscle invasive disease, patients are categorized as either low, intermediate, or high risk for recurring. So based on which category they fall in, some patients may be candidates for just a single installation of chemotherapy, whereas some patients who are at higher risk, it's really recommended that these patients receive long-term immunotherapy, intravesicular immunotherapy. We discussed a little bit of muscle invasive disease, and the goals of therapy here is really to aim to prevent progression into the metastatic setting. We talked about still the gold standard for muscle invasive disease is patients should undergo cisplatin-based neoadjuvant chemotherapy, followed by a cystectomy with pelvic lymph node dissection. And then in men, you want to make sure they undergo a prostatectomy, and in females, a hysterectomy. This really still remains the standard of care. A lot of providers, though, and the guidelines are beginning to support bladder preservation approaches. It's really reserved for a small subset of patients who are not at high risk for recurrence. They have shown good outcomes in patients who undergo bladder preservation. These usually require a complete resection followed by chemotherapy, chemoradiation actually.